My name is Golooba-Mutebi. I'm a political scientist and analyst. I study politics and I have an obsession in politics, as like some people who are obsessed with football. I spend all my time watching and listening to politicians, and I'm privileged to have Mary here in front of me to help us understand what the NUP seeks to do better than the NRM. Today the conversation I want us to have is the how and why and when and when. Now, beginning with health, the NUP has this very broad aspiration as far as health is concerned. If NUP won the elections and NUP became the government tomorrow, they have this big aspiration for the health sector. And that aspiration is giving equal access to quality health services to everybody.
Yes.
Equal access to everybody.
Yes.
Now this is very exciting, and anybody reading it and stopping there would say, wow, these guys are going to save us from the perpetually poor quality service, poor quality health services that the NRM have been providing. Even in the 34th year of their government, health services are still very poor quality.
Yes.
As we have been seeing on Twitter and other channels, there has been of late a very, very angry debate concerning the government's management of COVID. Our hospitals don't have intensive care units, they don't have beds, they don't have medicines, they don't have adequate staff, they don't have other supplies.
Yes.
So there is an angry debate going on. Under normal circumstances, we Ugandans had got used to this. This is the way our healthcare system functions. And then COVID came, and the government raised an enormous amount of money, not only from Ugandans, who contributed vast amounts, whether we are talking individuals or we're talking about companies. But the government also borrowed vast amounts of money from the World Bank and other donors, again to fight COVID. So actually the money that the government raised might have outstripped what it has been putting in the health sector over several years. But still, we don't see where this money has gone. But now going back to this aspiration of providing equal access to quality health care to every Ugandan, my first issue that I want to raise with you and on which I would like to seek clarification for me, but also for those who are interested in the National Unity Platform and what it proposes to do for Ugandans. The NUP says access to quality health care should be a right.
Is a right.
Oh, okay. Well, currently it's not a right because we all don't have equal access.
It's not enjoyed, it's people are deprived of their rights, but it is inherently something that people should be are entitled to.
Now, under an NUP government, equal access to quality health care would be a right. Or it would be treated.
We would recognize it as a right.
Recognize it as a right.
Yes.
But possibly not just recognize it, but also put it into practice.
That's right, deliver.
Now, in the world of development, the development industry, as people call it, a question is usually raised about this. A right is enforceable, or a right should be enforceable. How would NUP ensure that this is actually a right, not only in theory but in practice?
In practice.
Yeah.
I think the fundamental thing is to provide national health insurance. There's a thing called the National Minimum Health Care Package that has been being discussed by this government for about 19 years, for a very long time. And under that scheme, we were meant to have universal, at least primary health care. It was meant national insurance scheme. And so I think already this nation recognizes it as a right because it has been planned before. The trouble is that plan has never materialized. Now, how it could be brought about, I think, would be by increasing the levels of competence in government. I think it's not an impossible goal to achieve, but it has been undermined by both corruption and incompetence, as have most other sectors. Now, that scheme was introduced after a very expensive loan was taken for a study. The loan wasn't for hospitals or anything, it was for a study.
Right.
It was called the District Health Services Program or project. And the idea was to study the situation, devise a means, models for national insurance, how would the money be raised, what model to use, and then pilot it in the districts. And that project took off. It was in '97. The pilot study never took place. And it didn't take place because apparently they ran out of time. The planning on the World Bank level was bad. In fact, after the project, they have what they call a completion report. It states that the project was badly designed. So the outcome was we didn't actually have a plan, a national insurance plan that was tested. What they did is they just implemented a model in the countryside in a few districts. They tried to roll it out, and part of that was cost sharing. I don't know if you remember the era of cost sharing.
Yeah.
And very quickly it died out. Government just abolished it. And one of the comments was that the consultants didn't understand the political economy, because cost sharing was being brought in at a time when we were having elections and it was a vote closer. So all that is about competence, not just on the part of the Uganda government, but on the part of the World Bank as well. So what I'm trying to say is that we can do it properly. We can devise a model that will work. Yes.
Okay, it's good that you raise the point about health insurance. But there is an issue that's normally not discussed adequately with regard to provision of healthcare, especially to poor people. Now, if on the one hand you say access to health or access to good quality care should be a right, or is a right that should be ensured, and then you talk of health insurance, there is always a question: should healthcare be provided on the basis of the taxes that the citizen pays, or should the citizen now again pay extra, which is paying insurance premiums in order to get access healthcare? And if we are going to have health insurance, how do we ensure that even the poor person who lives in a rural area, who doesn't have a formal job, who doesn't have a regular income, is going to be able to pay their premium in order for them to be included in this access for all? Because you see, access for all is a good idea. But when it comes to the mathematics of how to fund this health care that should provide access for all, there are some complications. Should we do that on the basis of the taxes we pay? Should we have, if we say we are going to do it on the basis of the taxes we pay, somebody could argue that actually taxes are not enough to finance a functioning healthcare system, because even in richer economies, healthcare services can be free, but they're free sometimes only in theory. People have to use private care. Some people have private insurance, and those that use public provision sometimes find that the services are not as good as they should be. Now, if taxes are not enough, there has to be something else. Now, NUP is proposing insurance. Now, can you give us some more detail about how this insurance, or whether NUP has already thought through this insurance, whether this is something that you propose to think through when you're eventually there?
Insurance is a threatening word. I think it can be intimidating because it gives you a picture of, say, like car insurance. But the models I saw being discussed involved sums like 1,000 shillings a year. It was calculated, I think the data shows that a person is likely to get malaria 4 times a year. It was on the basis of that. If you got malaria, which is, I think, the most prevalent illness, 4 times a year, and you're a family of 5 and everybody got malaria at that amount of times, what would be the cost implication? So you can calculate the cost implication for the family to pay 1,000 shillings, a family of 7. You can also count the implications of not getting the treatment, the cost of that, in terms of lost production, in terms of the person is going to wind up in hospital anyway, a government hospital, and take up space and require drugs. And if the treatment isn't very good, the treatment is unlikely to be successful. So you're already paying for the malaria. The difference is that you're not getting the outcome you want. So that's the first thing. Secondly, the health sector is meant to be receiving 15% of the budget under various international treaties, of which Uganda is a signatory.
Yeah.
So with 15%, you can have a basic minimum. Without the 15%, we are now, I think, 8% budget share. But when you look at what the rest of the budget does, the biggest share goes to the Ministry of Works for roads and other infrastructure. Then the second is security, which is massive, 10% plus. Then interest on loans. Then you have education, health, agriculture is 4%. So it's a question of priorities. We believe in NUP that we have the money. It's a question of how we use it. Incompetence and corruption. Yes. But just to revisit your point, I think the people who are going to most want the National Health Insurance Scheme are able to pay 1,000 shillings a year. They are able to pay that. After all, they pay taxes, the fishermen pay taxes, they already pay taxes. They pay taxes to work in the markets, and a lot of that money is what keeps the districts running. So we shouldn't immediately assume that Ugandans can't afford 1,000 shillings a year. They can't afford to look after themselves.
Yeah, I think the issue there, Mary, is that at the time this issue was being studied, when they came up with this figure of 1,000 shillings, that's some time ago.
Yes, 1,000 shillings is the model. Okay, let's say 5,000.
You may find that going, say, in the next 2-3 years, it might actually be 5,000
yes.
or 10,000.
5,000, yes, or 10,000. True.
There might be Ugandans who claim or who insist that this is too much. And if we get to a point, and you know, the other thing is that Uganda, we like to style ourselves as a competitive multi-party democracy. NUP is in power, NUP is suggesting health insurance, suggesting that maybe every individual pays 10,000, 5,000 shillings, maybe every household. Opposition opposition parties jump up and down and say, no, this is too much. And they say, oh, well, you're paying taxes already, why are they taking this money from you? You find yourselves caught up in a controversy where certain groups of people in this country say, we can't afford that kind of money.
I can see that happening amongst competitors, as you call them. But the point is that even with income tax, not everybody pays the same amount of income tax. You pay what you are able to pay. Isn't that the idea?
You pay what has been assessed, not what...
And they assess what you are able to pay. They assess. The assumption is that you're able to pay what is assessed. They don't just say that everybody's going to pay 1 million shillings a year. So why not the same with health insurance?
Yeah, that's an interesting question. But the places I have seen where health insurance has been attempted, or where health insurance has been popularized to the extent that the vast number of the population having health insurance, and Rwanda is a good example here. It took a lot of controversy for the Rwandans to get there, actually, because Rwanda is not a competitive mode but a democracy, as Uganda styles itself to be. There were no political parties opposing this policy, because their system is one based on consensus building. So all the political parties were behind the policy. But the donors didn't like the policy, because they said it's punishing poor people who can't afford the premiums. How are they going to be able to access health care if you're imposing these levies on them that they can't afford?
Sorry, at which point I would say they're not accessing it now. They literally don't have quality health care now. Over the past 2 days, I was looking at the districts of Rwampara and some other districts in the west, Mitoma, Rukunjiri, Isinjiro. And, in 2018, there was an audit of the biggest health facility in each district, whether that was a referral hospital, district hospital, or health center for. And if you look at the equipment, it gives you a list of equipment they're supposed to have and equipment they don't have. And mostly they don't have it. This is in theater, this is in maternity. Basic things. Something for cesarean section, delivering a baby by cesarean section. If you don't have anything to begin the operation, what are you doing? You're not providing the service.
Yes.
So what I'm trying to say is that they're not receiving the service anyway. Then the staffing, there's a staff audit for all the government health facilities. And hospitals are run, it seems, by there's a lot of consultants at the top of the list, senior consultants, then consultants. That's about 15 people. And then towards the middle you have medical officers, special grade. That's where you begin to see people in place. Everybody else is missing. So there isn't a health service. If we accept that, we'll then accept we have to do something about it. And if it can't be afforded, we have to raise the money to do it.
Yeah, so the proposal you're making is one of looking to health insurance to supplement taxes that people pay, to build a healthcare system that provides equal access
That's right.
to everybody. So, as far as an NUP is concerned, this is just a question of money. If the money was there, this would be done.
Administration.
You did mention the 15% of the budget as required, I think, by the Abuja Declaration. So for you, this is just money.
No.
If you had resources, you would build a healthcare system that functions as it should be.
I think you're talking about administration, which takes in money, administration of resources. Because there has to be a reason, and it's poor administration, why a hospital or a health center would have an X-ray machine, an X-ray that is not used, that has not been used for years. Same with other pieces of equipment. And there are pieces of equipment that are in good working condition, but they lack batteries, so they're never used. A doctor was telling me yesterday that they used to have a pull system for supplies. So the hospitals themselves would say what they require and requisition it. He says that was slowly overtaken or quickly overtaken by the push system. So now the ministry tells you, you are getting this equipment. Never mind that there is nobody in the establishment trained to use that equipment, and there hasn't actually been for a long time, or there's never been. So it's about administration, it's not just a question of money. And when you get the goals right, and the administration right, then you'll know how to spend the money, and you'll realize 7% is not enough to run a quality health sector.
I'd like to push you a bit, Mary, and insist that ultimately it's money. Because for you to get a good administration in place, you need qualified people to form a competent administration. Now, the current government may argue that this competent administration is not there because of limited resources. Because, as you said, all audits of health facilities in this country show gaps. There are technical positions that are not filled. I would like to argue that it's because the pay is not good. It is because things like housing don't exist. It's because other incentives that might attract qualified people to go and work for hospitals do not exist. It might be that, and I think it is, that the money allocated to the health sector is not enough to buy medicines to stock hospitals adequately. And I saw a doctor 2 days ago on Twitter, I think this doctor works in our hospital, was lamenting seeing patients die, not because there's nothing that can be done, but because the doctors do not have what they need to do what is required.
Yes.
Now again, I say all that it seems to me as if the issue is really money. Because even a competent administration must be built by money. Qualified people, but yeah, money still comes into the equation. Now when you mention 15%, and there have been attempts also to, by international agreements or conventions, to say health should get 15%, agriculture should get 15%. I remember having a conversation with a senior bureaucrat at the Ministry of Health, asking him why it is that health doesn't get the 15% that the government of Uganda signed up to, and why agriculture doesn't get the 10% that they signed up to. And he said, oh, well, if you go around parceling out the budget that way, you allocate 15% to health, you allocate 10 to agriculture, you allocate maybe 15 to education, then where is the flexibility in the budget? Because it says a good budget must have inbuilt flexibility so that the monies go where they're most required at any particular moment, rather than straight jacketing the budget and saying, well, 15% here, 10 here, 40 here, 30 here.
I understand that, and I also imagine that it was based on something. It wasn't just a figure snatched out of the air. I think the idea was that it is an optimum under these circumstances in sub-Saharan Africa. I don't think it's just a figure plucked out of the air. But apart from that, did that person explain the basis for what do they spend on security? Is it 13 or 11% of the budget share? So 3 or 4 times the amount they spend on agriculture. What is the rationale for that? You see, what you just said about inbuilt flexibility and everything doesn't actually say anything. Whereas the facts are that even the auditors sometimes don't know what the money is spent on in the security sector. we're seeing it now. We're seeing that they never run out of weapons of destruction. They never run out of that. So we need to be more honest with ourselves. And let's demystify the budget. I think we try, technocrats have tried very hard to mystify the budget and confuse everybody. But it's really simply a matter of spending less on security. Another big thing we have in our manifesto was the elimination of waste. In the early 2000s, late 90s, early 2000s, waste wasn't seen as an issue. You see, if you, things like 200 million shillings lost to ghosts on the payroll. It wasn't considered, it was a problem, yes, but it wasn't considered a huge thing because it was just beginning, the payroll fraud, or it was just being discovered. But now that that has grown, you find that if you arrest the waste, you can then reinvest the savings. So we actually looked at the budget, and we looked at areas where savings can be made, and we found 3 trillion. And the exercise is ongoing, obviously, because we don't have the access the Auditor General has, but we found already low-hanging fruit of 3 trillion shillings.
And what is this 3 trillion? Where did you find it?
It's in the budget, in the actual votes and sub-votes and items. Yes.
How is it there?
How is it there?
Explain it to us.
Okay.
What did you look at to establish that there is 3 trillion shillings in the budget, which you identified?
Okay, we looked at the narrative for the vote. So when you have, for instance, in the Prime Minister's office, you have a vote for welfare, and you go into the details of what that means. All that means is coffee and things to eat during meetings. That's what welfare means. Welfare in the police will mean something else. In the police, they may have different welfare requirements. But there's a whole raft of ministries, particularly in central government, that squander resources on things like that. When we're having a talk here and we don't have any flags or banners aren't a lot of money. There are a lot of money when there's no oxytocin is what? It's a basic drug. It's one of the ones that they're called tracer drugs that they monitor to see how we're doing in terms of drug supply. Yes, and oxytocin was missing in Butoma for I don't know how many days, 2 months or something like that. Now that's a basic frontline drug. So what I'm trying to say is we have the money, we can reallocate from security, we can save money from waste, and we can also, and that will be the seed for the National Insurance Program. Government has to seed it. And so the amounts that people would have to pay into it would be minimal, especially people that don't have money to pay into it. It won't be a flat rate.
Okay, I would still think that although you won't admit it, at the center of your proposals is budget, money. You will need money to do all these things.
Of course.
But let me change slightly from money to something more practical. The Museveni government abolished graduated tax some years ago in the heat of an election campaign. I think it may have been 2010, if I'm not mistaken. And that is because people were resisting paying it. A lot of people were resisting, and therefore the government had to apply strong arm tactics to get them to pay. And this was causing some degree of dissatisfaction among potential voters. And the president himself had reckoned that if he abolished graduated tax at that point, it would do away with all this discontent regarding graduated tax. But they told us only one aspect of the story, that these graduated taxes, they are collected in a way that offends people, and this is not nice in a democratic society. What they didn't tell us was that also people objected to paying this because they didn't see the point of paying. Now, the health insurance schemes that I have studied show that the ordinary African does not necessarily understand the issue of health insurance. Cost sharing is easy to understand. You have malaria, you go to a clinic, they charge you 5,000 for whatever tablets they give you. You understand why you're being charged this 5,000, because you're ill and you have to pay for the service. Health insurance tells you, you pay now and you may use this money down the road. Now the story in other African countries is people say, but why am I paying when I'm not ill? I will pay when I'm ill. Now, by nature, health insurance premiums are like a tax. At least this is the way the ordinary person will understand it. Now that means that some people will resist, or some people will slacken, they will want to dodge, they will want to take as long as possible before they pay. Inevitably, the government has then to apply some compulsion. I saw this in Rwanda several times, where the government would have to apply strong tactics preventing people from going to markets and all that. And it has taken years for the state to find acceptable ways of getting people to pay. Now again, here you are, NUP in government, you brought a very good idea of health insurance, but people don't understand it. People are resisting it. They see it as extra tax. Have you already started thinking of how you get around this complication? Because you come into power in a competitive party system.
Yeah.
And again, I would say your rivals are quite happy to latch onto anything that is going to cause problems for you. People say, look, why are we being meant to pay for health care when we are not ill? We will pay when we are ill. How do you see your way around the complication?
The whole point with the National Unity Platform is that it will be a people's government. It's not a question of imposing something by force. I think that is part of the model that the World Bank fails to study. Rather than prescribing a system, we need to find out what are people comfortable with doing. It may be that with enough people, a proportion of people, which has yet to be determined, are prepared to pay for it, and they will be there, and they are there. Others who want to pay when they're ill will quickly come to realize that they're paying a lot more. They're paying a lot more than their insured neighbors, and they will begin to think about paying for it. So basically, and then of course, there's the issue of sensitization. And even with vaccination, there's a lot of pushback. There are people whose careers have been built on sensitizing people to accept vaccination. I have a friend who walked around all of northern Nigeria, door to door, just doing that. So basically, of course, we need to sensitize people. But at the same time, it's not such a radical thing. It's not such a radical thing. First of all, the act is on the table, yes, and it's a question of implementing it. So the psychological adjustment is already underway. Yes.
Okay, so at least I think that both you and I agree that these things there are complications or potential complications that the NUP has to pay attention to.
Yes, government is complex.
These ideas are good on paper, but when it comes to actual implementation, they do very quickly turn out to be complicated, and this is when people start saying, "Ah, but you see, they promised us this and they haven't delivered it. And they promised
Exactly,
this and
yes.
they haven't delivered it." So I hope that NUP is taking this into consideration. Now, again, going back to the issue of quality care, I have been studying the health care system in Uganda now for the best part of 25 years. There are things that are persistent. I first saw them 25 years ago when I was doing research for my doctorate, when I was studying primary health care. Today, as I read the media, the newspapers, these things keep coming up, and I say, but this dates back from 25 years ago. Now, shortages of drugs, shortages of equipment, shortages of personnel, all these things have been so persistent over the last 34 years. And I think we must give credit where credit is due. Under the NRM government, there have been some improvements. The National Medical Stores has improved its performance. It delivers more drugs than it used to, but still the shortages persist. Now, you as head of policy of the NUP, to what extent have you looked at the details of the factors behind these, the persistence of these challenges in the health sector? And therefore, the challenge, the drivers of these challenges that you're going to have to deal with. Because I don't sit anywhere and imagine that, the NRM government or President Museveni are just being malicious in allowing these things to carry on. There must be other reasons. Maybe they're malicious, I don't know. But I would like to hear from you as head of policy of NUP. Have you paid attention to the drivers of these things, or is this something that you're aware of as NUP that you must pay attention to in detail when eventually you get to government?
Okay, persistent drug stockouts are a persistent problem, as you say, for the past 20-odd years, and even the very, very recent hospitals audit, which was 2018, shows that it's very much present still. It goes hand in hand with the fact that the stores, many of the stores are full of expired drugs. Many. And I don't know whether those drugs find their way back onto the streets. The authorities must go to the hospital and oversee the incineration. And the story across the board was that nobody comes for the drugs. But the bigger point is that there are drugs that are still not used. And we have a lot of drugs that we throw away, or that are meant to be thrown away. So that brings us back to the competence question. I'm sure doctors could give you the answer. I think the problem may not lie with medics themselves who need drugs to treat their patients. I think the problem lies at an administrative level as to why these drugs don't find their way to patients. Also, the Auditor General commented that there was maybe a disconnect between what is required and what is sent, which is what that doctor, and it's the same doctor, by the way, that you referred to, the one who was speaking to me, said that it's the same, it's the push supply method, where you just say, we're sending these people this many boxes for this district, rather than looking at maybe the frequency requirement of that kind of medication. So there's no getting away from the fact that there's a lot of administrative remedies to be put in place, and to listen to the professionals. I just wanted to come to that point you made about doctors not having accommodation, poor pay and the difficulty of attracting.
But maybe before we go there,
Yeah.
just to go back to this issue of push and pull.
You're right.
Before the push system was introduced, they had decentralized the budget for purchasing drugs and supplies. Health units could order, large hospitals could order, and district medical offices could order their own drugs. And then it was discovered that that system was prone to exploitation by those who wanted to make money on the side. So it was riddled with corruption, and it had its own challenges. Even then, the system, the shortages were still there for different reasons. And then over the years, the NMS decided that actually the best thing to do would be, let's just study disease profiles across the country, so that we know that there is prevalence of malaria here more than here, there's this disease here more than there, so that they send these drugs in line with their study of disease profiles. Now it turns out that it's very difficult to predict whether this year this disease will be at this level or this level. So they send all these drugs and then they find that that year the drugs haven't been needed and they expire. So it seems to me as if between the push system and the pull system, neither is perfect. That each one has its own challenges. Now, of course, I think doctors loved the pull system because they could order exactly the little things that they needed.
For success, yes.
But again, it had its own challenges and there are reasons why they got rid of it. So again, it seems to me as if the NUP may have to be much more careful in deciding whether to restore the pull system or maintain the push system. Both have their challenges.
And that's where the flexibility you mentioned earlier ought to come in. You see, the professionals need a say. They have tried both systems. So they are the best people to turn to ask about a hybrid or an alternative, a hybrid. So yes, the people's government will be flexible, the NUP will be flexible in that.
Okay, now let's go to the issue of housing, which you were...
And other incentives, basically remuneration of doctors. I'm fortunate enough to have seen this with my own eyes. Where I come from, which is about 100 miles from here.
Which is where?
Which is in the Masaka area, beyond. There's a government hospital, and there is a doctor who works there. But he wound up living in our compound, basically. It was a sort of a little house that was used by somebody who comes there during the holidays. It was a very, very rudimentary structure, you know. And he was living there because there was nowhere else for a doctor to live. You don't really... There are some rentals, there are some big houses, but they tend to be occupied by the owners. And there are some smaller houses occupied by the... Basically, there isn't really a rental market. So when a doctor is sent out to rural areas, he's essentially homeless. And this is a fact. And this is why a lot of doctors don't actually go when they're asked to, when they're posted. I was very surprised the first time I heard of a doctor saying, I haven't got a job. And I thought, does that happen to doctors? And apparently it does, because the circumstances surrounding the job aren't ideal, and he not even ideal, but he just can't work under those circumstances. So you may remember that during privatization, government properties were sold. And even as we speak, government land is being sold. So the properties, the land on which you would have built hospitals, hospital accommodation for doctors, is being lost. In last year's audit, 2019, it was found that the majority of local authorities don't have the title for their health centers. They don't have the legal title for health centers and for other properties and for natural resources. So that being the case, they're unlikely to start building on the same property.
So that introduces another complication in as far as delivering quality healthcare is concerned.
Yes, but isn't it a question of the government, central government, giving them the title? The central government?
I don't know.
It is. It's a question of getting the title, you see, but for some reason that's not happening. What it does, and it's very suspicious, it exposes that property to land grabbing. Because if somebody just grabs it and there's no title, the district can't stop the grabber. The man has to travel, the woman has to travel to central government to try and get some kind of ownership, locus standi, to fight the encroacher. So basically, again, it's an administrative issue, and we do need accommodation. I think people now realize it, that you can't expect a doctor to travel in rural areas are very vast. Uganda is a small country, but the rural distances are far.
Yeah, actually, the lack of housing is such a problem that a few years ago, a colleague of mine and I went and spent a few days sitting at a rural hospital. We were studying something in the way the healthcare system in this district functioned or malfunctioned.
That's here?
Yeah, here in Uganda, somewhere about less than 200 kilometers from Kampala. We sat there for a few days. And we found this hospital had 6 doctors, but only about 2 would come on a daily basis. Well, every other day there would be 2 or 3, the others would be missing. And we asked the head of the hospital how he could allow something like this to happen.
He was turning up.
Yeah, he was turning up because he was the head of the hospital, so he had to run it. But he allowed the other doctors to come in
as and when
they could. So we asked him, how could you run a hospital where doctors do this kind of thing? And he said, hey guys, the problem I have here is that I enforce the rules strictly and my doctors resign and don't come, so that I don't have a single doctor here. Or I'm flexible and allow them to come, but also do other things, so that at least I have 5 doctors, of whom I will have 2 on any single day. And he said, first of all, they don't live here, we don't have housing, they live far away, so they must find transport to get here. The pay is inadequate, they must find other things to do, and he said, I'm just being pragmatic, because otherwise if I enforce the rules as I'm supposed to enforce them, I will lose all of them. Now, you see that again introduces a new element of complexity in providing quality care for all, and you can see where money is still in the thick of all this discussion, because we now have to build housing for doctors and nurses, because even nurses don't have housing, and many of the hospitals don't have housing for anyone. So now just think of housing at the hospitals that we have across the country. So here you are, NUP, you're in power, you have 5 years. Now you have a health sector where there are drug shortages, there are shortages of staff, there is no housing, paying for the services, is it tax, is it health insurance? You can see what a massive problem you're going to have on your hands.
Yes.
Whoever becomes your health minister is not going to even have what one would imagine to be a honeymoon, because you're being thrown in at the deep end. Now, there is this thing of, look, we don't have titles for the land, so you struggle to get the titles, and then you must find money to put up the physical buildings. Now, which reminds me again, when you're talking of waste in government, one source of waste in government is the contracting system, where companies bid for contracts. Now that system is wasteful in the sense that there is overinflation of prices. Now when I was teaching in Makerere, when I was working in Makerere, there's a small building at the university which was built for 400 million shillings. Now anyone with even the most rudimentary knowledge of what construction is about, of what it costs to build a basic structure, would think that the actual cost of that little building would have been less than 100 million. But they paid 400 for it. And I asked around, casually asked even some of the really high authorities at the university, and they were all saying, oh, well, what can we do? Because This is what do we call
Procurement.
it? The procurement system is designed in such a way that they must observe all these rules and these rules and these rules and these rules. So the suppliers build in a lot of extra cash because, again, the government does not pay on time. So you will find that you have to build housing at, say, 30, 40 hospitals, and then all this is going to be contracted out, and then you find yourselves having to pay lots of money to get structures that don't add up, as we have seen. If you look at the schools the government builds in the countryside, even the health centers, some of them collapse before they're even used. So I think that what I'm trying to flag here for NUP is that, your aspirations look good on paper, they're very exciting, but I'm saying, have we thought of the details of how this gets done? You can't give me the answer here, obviously, but as head of policy in NUP, I think that you will appreciate that this for me is a call to dig deeper.
Yes, I'm surprised you would imagine that we hadn't.
No, I'm not saying you
Thought
haven't.
about that.
I'm not saying you haven't.
Okay.
If you have, I'm going to request you to give us the story.
All right. We have infrastructure. You know, most of the hospitals were built in the 50s.
Yeah, yeah,
They're very old.
yeah.
So those are the established hospitals. Health centers too are quite old, and some of them are newer. And then there may be new hospitals. But there is an uneven spread of facilities in both education and health, by the way. So what is being done currently by this government is that they have borrowed, the loan goes up to $730 million. So far they have drawn about 300 million, and it's called the Uganda Intergovernmental Fiscal Transfer, or UGIFT. Fiscal Transfer Program. Under that, they're meant to be building hospitals or extending hospitals that exist. So if it's a health center 3, which is really a clinic, a day clinic, they will add a maternity wing. So it becomes a health center 3. Health center 2 becomes health center 3. Health center 3s can become a health center 4 if a theater is added. Okay. So that's on the health side, and just because it's in the same program, on the education side, they build what they call seed schools. I'm not sure why they say seed secondary school, but they're secondary schools being built from scratch, very big, with science labs and everything. And on the primary school side, they may build classrooms, a hall, basically increase the infrastructure, the physical infrastructure for primary schooling. Now, this is for the disadvantaged districts, or even parts of districts where you don't find enough of those facilities. And for the facilities I've looked at, the health centers are costing 400 million shillings, between 400 and 500 million shillings to build a maternity center. On very many of them.
Which has no equipment in it. This is just the building.
It's the building. It's the building. It's on the school side where I saw that some of the bidders were adding fully furnished schools. But on the health side, I'm not sure that there was equipment.
Yeah. Now this takes us to the issue of.
Sorry, can I just finish that? So the intervention that is happening now is that they borrowed money. Money was borrowed for this project. You mentioned procurement. A lot of the projects did not get finished on time, or if at all, because it was inspected last year, so you'd have to go back this year to see if the unfinished ones are now finished. But the reason they didn't is they started late. The reason they started late is because of the procurement. So what they decided to do was to give one firm in every area all the contracts. So if it's a question of health centers, you have one company doing health centers in 2 or 3 counties. And I think the same with schools. And time after time you see that they just didn't have the capacity. Procurement caused huge problems. Late finishing. There's a significant number of facilities that were abandoned, time after time, abandoned by the contractor. The contractor has not been seen for 2 months. Now, that in government usually points to a wrangle over money. Maybe the contractor had to pay a kickback and is no longer able to cover the costs of the building. Various things like that, because you find also that money remained on account. So the contractor is in place, the building is halfway up, and the contractor isn't paid any more of that money, and the money goes back to the consolidated fund at the end of the year, and the contractor leaves. So there's something to be understood there. Yeah.
Now, you see, there is an interesting story there which was told to me by a civil servant, a senior civil servant, who gave me the example of the hospitals which you mentioned, which were built in the 1950s. If you look at Kiriandongo Hospital, if you look at Bujiri Hospital, and others, they look alike. The structures are exactly the same. And it strikes you when you travel and you see these hospitals, the way they look the same. Now, this senior civil servant told me that actually the trick was to do one design for all the hospitals, so that you could predict the quantity surveying reflected exactly what you needed to build that hospital in Adjumani, build it in Arua, build it in Iganda, build it in Kiriandongo, so that the costs could be estimated ahead of time. Now, these days, if you see how hospitals are built, Chirudu looks different from Kawempe looks different from Mitiana, so that the waste of money entailed in building this.
Redesigning.
Yes, redesigning all the time. Because this guy said we could save a lot of money if we just borrowed this very simple idea that the government in the 1950s had, building hospitals that look exactly alike. Because then there's no padding.
It's the same with police stations.
Yeah. So now we have, and again, this takes us to the point I was raising, that yes, there is waste, but some of this waste now, if you look at our procurement system and our procurement laws, which were given to us from sources, external sources. I think that the organizations like the World Bank are the ones that design these things for us. Now, these things might work in their own countries. But when it comes here, they make each government project about 10 times more expensive than it should be. And I have been arguing with people that actually what we need to do is look again at some of these procurement systems and other systems that we've been gifted by outside actors. Do they actually serve in the interests of this country? Or have we fitted ourselves in things that are actually just siphoning money out of the system and making it impossible for the government to provide services in the way that it should be?
Well, I'm glad you brought up that example because it answers the question. If you say that the cost of providing the infrastructure for health and education services is inflated by a factor of 3 or 4 by the procurement systems, then that is how we will fund it, because we will reduce the cost and reinvest the money in the actual services.
Yeah, which again means, and I'm going to push you on this a bit, which means that you have a 5-year period in which now we are discussing the health sector. We will go on to education. Next we will go on to agriculture, and you will see that in all these sectors across the board, the problems, the challenges are just pretty much on the same scale, and it's large scale.
It's huge.
So the government, NUP, you come into government, you're inheriting a vast amount of problems that you need to fix. You have only 5 years to do it.
But why would you want to do something in 5 years?
Because I'm assuming
That
you've been elected for 5 years, and who knows, you may have 10 because you might be re-elected, but you may,
Yes,
have only 5.
but we need to be honest. If in 5 years it is only possible to build, for instance, rooms, or rooms as an extension to a hospital, then we would be honest enough to say so. You have to keep the people involved in what's happening because it's their lives. We would like very much for people to participate more in budget formulation. So these are the resources we have, and this is what we need to do. You choose what are we going to use it for, so they know what's going to come out. If it's just, as I say, a little bit of increasing the accommodation slightly, then we'll do that. But we can't promise to do things which we are sure can't be done in 5 years.
You have a promise already.
Which is what?
The promise is access to quality care, equal access to quality care.
Yes, definitely.
But you have all these enormous problems that might mean that you can't possibly provide.
Yes, we have problems, but we don't say that they're insuperable. Because if you haven't built all the houses for doctors yet, you can remunerate them in a way that enables them to get accommodation. Let's not tie this down to physical housing for doctors.
So does that mean that then maybe it makes more sense to not flag this as a commitment, but as an aspiration?
No, it doesn't.
You would still...
I mean, we've had this discussion before.
Right.
It doesn't.
You would still say it's a commitment?
It is possible. It is possible.
Yeah, but
all I'm saying is that the way in which you are looking at it, saying that it can't be done if doctors don't have accommodation. If the government is unable to build doctors' accommodation, then we should be able to remunerate doctors so they can rent or build their own accommodation.
No,
so the accommodation is not going to prevent us from providing quality health care.
No, actually, my argument is not that it can't be done.
Yes.
My argument is that it's complicated. That NUP, in making this commitment, it would be from my own, from where I see it, it would be nice to not give it as a commitment and say, okay, this is what we aspire to do, because I have spent all the time I've been here trying to show loopholes and saying, look, there is this and there's that and maybe not
challenges.
Challenges.
Yeah. You're being sneaky. They're not loopholes, they're challenges, which the NRM has failed to meet and which we are going to meet.
Okay.
Yes.
Okay. So that's it. Now, the last one before we move on. There is a discussion which again we haven't had in this country, which I wish we could have more of. And this issue is the balance between primary health care and tertiary care. Now, when I started studying health here in Uganda, the World Bank again and other donors had told us that we had spent so much time building hospitals, large hospitals, the Mlagos and the Chiriandongos and so on and so forth, and that we hadn't spent enough time building primary health care facilities. And so the attention of the healthcare system was reoriented from thinking big things to thinking small things. Health centers, 1 to 4, those kinds of things. Now, that again sounded very attractive in theory. That for once, the government is not addressing the needs of the elite as it was put at the time. That governments are just interested in people who live in towns, so they build these big hospitals for them because this is their constituency. So now let's take money to the countryside and build these things that are going to address the needs of the peasantry. Nice theoretical idea. It turns out that 2 decades down the road, or 25 years down the road, we have now realized that actually in concentrating on those small things, we neglected the hospitals. So that our tertiary, the quality of tertiary care in countries like Uganda is so abysmal that all our leaders troop outside the country, and I'm sure you know this. Once they're ill and they have something that needs more than just a bit of specialized care, they're off to India, they're off to Nairobi, they're off to all kinds of countries. Now, a doctor friend of mine once told me a story, just to illustrate this, because I first heard this from a medical doctor. He said the day I met him, we were having coffee, he says, you know what, we made a terrible mistake in listening to the World Bank on this issue. Because that very morning, the mother of his colleague in one of our big hospitals had just died. And she had died while being transported on a pickup truck from Kumi to be brought to a hospital in Kampala. And she died on the way. And he said, look, how can it be that between Kumi and Kampala there is not a single hospital that could have handled this lady's problem? That she would have had to be driven all the way from Kumi to maybe Zambia, maybe Malawi. But in between Kampala and Kumi, there is nothing. So again, you as NUP, how do you deal with this issue? Because the issue of primary health care, addressing the needs of the poor and so on, yeah, this is very attractive and donors are very keen on this. But clearly we have a problem.
You're assuming that the poor won't need tertiary.
No, I'm asking, what are your reflections on an issue like this?
Oh, okay, so just for the benefit of the viewers, can you define tertiary care?
Tertiary, I'm talking of higher level health facilities where they can operate, do heart.
Oh, where you can have surgery.
Have surgery of different kinds.
Okay.
Do
diagnosis
of
rare diseases.
Yeah. That in Uganda, only in Kampala we have hospitals that remotely possess this capacity. And we have spent the last 20-25 years building Health Center 2, Health Center 3, so that somebody who is in Kumi and has a serious problem that no health facility in Kumi can take care of has to be driven all the way from Kumi to Kampala. But also you had a problem given the motor accidents that are so widespread in this country. You get into a serious motor vehicle accident on any of our major highways, it's very unlikely that you're going to be anywhere near a hospital
that can deal with it. Yes. I wish I had a map in front of me. I'd like to see what facilities are probably exist between Kumi and Kampala.
There must be Tororo, there must be Mbale, there's Soroti, there's Iganga. All those couldn't handle this lady's problem.
Okay, right. Also, the nuclear medicine unit in Mulago. Okay, it's one of the few in Africa. Nuclear medicine isn't something widely available. So I know that you need to travel from all over the country to just access that diagnostic facility. Isn't it the same challenge as the rest of the sector, primary and secondary and tertiary? It's a question of the doctors being available. Because it's not just equipment, because we have equipment in some hospitals for which there's nobody trained to operate. So it's the same thing. If you don't have a doctor on site handling malaria, it's unlikely you're going to have a doctor on site handling cancer. The same thing about attracting and retaining the skills at those facilities. And one thing that will attract the skills is, apart from remuneration, I think doctors like to be able to do their work. So he's not going to go to a place where there isn't equipment.
Yeah, but as NUP,
Yes.
what are your reflections on what has to be done to redress this balance? That we have a malfunctioning primary health care sector in the subsector into which we pumped vast amounts of money
Yeah.
at the expense of a tertiary sector that has virtually collapsed. So, what are your reflections on what you need to do?
My reflections, to be quite honest with you, are that we're not talking about two different problems. I really don't see a dichotomy. I don't. I see it as the same problem. Attraction and retention, and creating the physical infrastructure for the services to be spread evenly across the country.
Yeah, I'll keep buying on about this one, attraction and retention, money again.
Yes.
But going back to the point you raised there, again I'll give you an anecdote. When I was a student, I used to be part of a Ugandan discussion group. I was in Europe at the time. And in that discussion group there was a surgeon, a Ugandan surgeon, famous trauma surgeon based in the United States. And I took the opportunity to ask him off the discussion group and say, why are you working in the United States? Why aren't you in Uganda? And he says to me, for me, I'm past that stage where I work to make money. So I've made money. And I would love to come back to Uganda, but come back to Uganda to do what? He said, I'm a trauma surgeon. How much equipment is there in any hospital in Uganda that would allow me to work as a trauma surgeon that I have been trained to be? So, none. So I come back to Uganda to de-skill. What am I coming to do? Now that made me think, and I was still at university at the time, and I thought, Now years later I got to work in South Africa. I was working at the University of Witwatersrand, and I'm based very, very far out of Johannesburg, 650 kilometers northeast of South Africa. I'm doing field work there in a very rural context. There are about 5 hospitals in the sub-region, and each one of those hospitals has a medical superintendent in Uganda.
Wow.
They're all Ugandans in this rural backwater of South Africa. And we used to meet occasionally. We would meet as Ugandans at somebody's residence, and again I'm asking these guys, but guys, how come you guys can't go and work in Karamoja, for instance? You're here, this place looks like Karamoja, because this is in Mpumalanga. In fact, it was one of South Africa's poverty nodes, one of the poorest parts of South Africa. And then so many Ugandan doctors there. So I asked them, but guys, why is it when you're in Uganda, they posted you in so you don't want to go there. If they put you to Karamoja, you don't want to go there. So why are you guys here? And I said, yeah, because here we can be doctors. So you see here, the hospital has housing. I have a good house that I live in on the premises of the hospital. The government will give me a loan to buy a car. They pay me enough to survive on. If the government of Uganda, if the government in Uganda did the same in Karamoja, I'd be happy to go and work in Karamoja. And again, I leave South Africa thinking, but really, this sounds like an easy problem to solve. But maybe it isn't. And I'm putting to you again as head of policy in UP. Major challenges for you there. How do you attract and retain our doctors who are living in the Karamojas of South Africa?
Well, the first thing you do is you engage them. Because you want their views. You have found out these things from speaking to doctors. I don't know whether government spoke to doctors before they began to do the things that they were doing. Ugandan doctors, not consultant doctors from the World Bank. So that's how we will address it. You see, that's the whole essence of it being a people's movement. Because we're not trying to pretend that we're going into this thing knowing all the answers. The difference between us and the present administration is that we are prepared to listen, to find out, and we're open to implementing the best proposals from the people concerned, from the stakeholders. I think it's the political will, if you like. Yes, but as you say, those are the things that affect the retention of doctors, and I think we say so in our manifesto that there is nowhere for them to live. Same thing with teachers. Even when they built those extra primary school classrooms with the YouGift loan, some classrooms are transformed into teachers' accommodation. Because you need teachers, and there's no point having a school without teachers. And if it's in a hard-to-reach place, you're not going to have teachers. So basically, you need to look at the whole doctor, the whole nurse, the whole professional. Where do they live? Apart from how much do they earn? And I think we must be careful not to do the doctors a disservice. There are many, many, many doctors who work for way less than they could earn in other countries or in other hospitals in the private sector, but they still choose to serve. So I think when we talk about it, we shouldn't boil it down to shillings and cents necessarily. Doctors, as you say, want to serve, and nurses want to serve.
Okay, thank you very much, Mary. I'm sure this is just the beginning of several conversations on these topics.
Thank you.
It's been interesting listening to you, and I look forward to listening to more of this.